Hello everyone, and welcome to the MedGuru CDB YouTube channel for medical students, aspiring physicians, and doctors-to-be. Let's go over the crystal ball and what the guru thinks will come out in cardiac physiology. So for this short session, we're going to go over the must-know principles under cardiac physiology, and the official reference is going to be Byrne and Levy, Principles of Physiology, as well as your Guyton Physiology. So let's start. Now, as you can see in this table, this shows you the distribution of blood. It would be crazy to memorize these values. So let's interpret and what most likely will be asked in the exam. And that would be, as you can see, small veins, large veins has the most distribution of blood. So the volume of blood in the systemic vascular system is greatest where? In the veins and the venules. So your reservoir of blood is found in the veins and the venules, your reservoir of blood. Now, reservoir of blood is found in the veins, and the exchange of nutrients and gases occurs in the capillaries, while the highest peripheral resistance is found in the arterioles. So as you can see below, on the left is the artery, on the right is the veins. The vein is the blue, the artery is the red. Then you have your arterioles, the venules, then the capillary network. So reminder, take this to the boards. Highest peripheral resistance is the arterioles, venules and veins is the reservoir of blood, and the capillaries is where there's exchange of nutrients and gases. Now, some basic must-know principles about the functional anatomy of the cardiac muscle. The cardiac muscle functions as a syncytium. So what do we mean by a syncytium? This means whenever a stimulus is applied to any part of the cardiac muscle, this would result to a contraction of the entire muscle. So the cardiac muscle functions as a syncytium. So it is indeed true that the heart beats as one. Now, something very important which you find in the cardiac muscle is the presence of your intercalated disc. Now, if you look at this illustration below, these dark areas which cross the cardiac muscle fibers are known as intercalated discs. Now, the gap junctions are present in the intercalated disc in between adjacent cells, and this would facilitate the fast conduction of the cardiac impulse from one cardiac cell to the next. So don't forget one of the pearls of the cardiac muscle, and that is the presence of your intercalated disc. Now, another pearl to remember regarding the cardiac muscle is the cardiac muscle is very, very rich in mitochondria. Why? Because this is for ATP production. If you remember, the mitochondria is the powerhouse of the cell. And at a biochemical level, don't forget the inner mitochondrial membrane is the site of oxidative phosphorylation, which is the synthesis of ATP, which is coupled to the electron transport chain or the respiratory chain. So the mitochondria is the site of oxidative phosphorylation. Now, something very important for the boards or any exam in physiology is your ryanodine receptors. So what are these ryanodine receptors? You will take note that these are found in your cardiac muscle. So as calcium leaves the sarcoplasmic reticulum, they will leave through release channels, which we call the R receptors or the ryanodine receptors. This is specific for the cardiac muscle. Now, what is your clinical pearl? The condition known as malignant hyperthermia. So why does malignant hyperthermia occur? This is because of an increase in metabolism due to a rapid, I will repeat, a rapid and uncontrolled increase in calcium within the sarcolemma. And this involves your ryanodine receptors. Now, pearl for the exam. What are the two common anesthetics which are associated with malignant hyperthermia? It is number 1, succinylcholine. Succinylcholine is associated with malignant hyperthermia. So please take note of that. Halothane is also associated with malignant hyperthermia. So, additional clinical pearl. The treatment for malignant hyperthermia is the drug dantrolene. What is the mechanism of action of dantrolene? It will inhibit your ryanodine receptors. So your dantrolene is considered to be a ryanodine receptor inhibitor. Now, another pearl to remember under cardiac physiology is your ANP or your ANF. Now, what is ANP? This is your atrial natriuretic peptide, and your ANF is atrial natriuretic factor. Your ANP is a hormone which is secreted specifically by the right atrial cells, and this is secreted in response to stretching of the atrial wall, or whenever the right atrial pressure increases. So when there's volume overload, this hormone, atrial natriuretic peptide, will be produced by your right atrial cells. So what is now the main function of ANP? The main function of ANP is to cause a reduction in the expanded or overloaded extracellular fluid volume by, memorize this, increasing your renal sodium excretion. That is why it is called natriuretic. So increasing the excretion of renal sodium. Then we have another clinical pearl, which is your brain natriuretic peptide. This is also secreted by the cardiac cells, but this time it's secreted by the ventricles. So ANP, letter A is the atrium. Ventricles is the brain. So don't forget, letter V is ventricles, letter B, the brain, or why not, the brain and the ventricles. So the effect is similar to ANP. Now, what is the clinical application? The half-life of your BNP is 2 times longer than that of ANP, which makes it a better choice for being a diagnostic test, most especially for the assessment of congestive heart failure. Now, memorize this. I can smell this in your board exams. Phospholamban. This protein normally inhibits the calcium ATPase of the sarcoplasmic reticulum of the cardiac muscle. Now, please remember, the sarcoplasmic reticulum is the organelle in the cardiac muscle which releases the calcium and it sequesters the calcium. So during muscle contraction, the sarcoplasmic reticulum releases the calcium, and during relaxation, the sarcoplasmic reticulum sequesters the calcium. So what is phospholamban? It is a 52 amino acid membrane protein that regulates the calcium pump in your cardiac muscle cells. So phospholamban is a 52 amino acid integral membrane protein that regulates the calcium pump in your cardiac muscle cells. Now, let's quickly go over the cardiac cycle, where we have 5 phases. It starts with phase 0, phase 1, phase 2, phase 3, then phase 4. So let's go into quick detail. Phase 0, also known as the rapid depolarization. This is phase 0. This is related almost exclusively to the influx of sodium. So here, this is your fast sodium channels. Clinical Pearl. What toxin blocks the fast voltage activated sodium channels of the heart? It is your tetrodotoxin, which is one of the most potent toxins known to man. This tetrodotoxin is found in your blowfish or your pufferfish. So don't forget, tetrodotoxin, pufferfish, this is sodium channels. Now, phase 1, this favors the efflux of potassium, as you can see in this illustration. And this is through the ITO channels, your ITO potassium channels, or your transient outward current channels. This phase 1 now corresponds to the early partial repolarization. Early partial repolarization. The application comes later in pharmacology, most especially for your antiarrhythmic drugs. Phase 2, as you can see in phase 2, it flattens out, or there's a plateau. So there's now an influx of calcium, and this is balanced by the efflux of potassium. So plateau is phase 2, or phase 2 is plateau. So please take note of that. Phase 3, the curve now goes down. This now favors the efflux of potassium over the influx of potassium. So 2 things happen here. Potassium going out, that's the efflux, and potassium going in. But what is favored is the efflux. Lastly, phase 4. So the chemical forces will now favor the efflux of potassium. Now, memorize this by heart. The cardiac muscle has 2 types of calcium channels. We have the L type and the T type. The L type means long-lasting, T type means transient. Now, the L type calcium channels, memorize this for your exams. What is the predominant type of calcium channel in the heart? It's the L type. So don't forget, the heart is full of letter L, love. And the L-type calcium channels are blocked by drugs called calcium channel blockers. To give an example of what's cited in your physiology textbook, verapamil, amlodipine, and diltiazem. Now, some terminologies to bring with you to your exam. What phase of the cardiac cycle is ventricular volume the lowest? So this is your isovolumetric ventricular relaxation. The phase of the cardiac cycle where ventricular volume is the lowest. Isovolumetric ventricular relaxation. So what is the clinical pearl here? It is during the isovolumetric ventricular relaxation where you would encounter the second heart sounds. And don't forget, the second heart sounds anatomically is caused by the closure of the letter S, since it's second letter S, your semilunar valves. Now, I want everyone to remember basic autonomic principles. Always remember the parasympathetic nervous system. Parasympathetic, which would be muscarinic receptors. This is inhibitory to the heart. So the receptor that mediates the slowing of the heart is your muscarinic receptors. Again, basic autonomic principle. Parasympathetic nervous system is inhibitory to the heart. The muscarinic receptors, which are parasympathetic or cholinergic rather, are responsible for mediating the slowing of the heart. On the other side, sympathetic stimulation, which is adrenergic receptors, would excite or stimulate the heart. Now, your adrenergic beta 1, memorize this. The adrenergic beta 1 receptors are the autonomic receptors that mediates an increase in the heart rate. So let's put these two principles together. What slows the heart rate is the muscarinic receptors. What increases the heart rate is the adrenergic beta 1 receptors. Your clinical pearl, beta blockers, or drugs that block your beta receptors would lead to a decrease in the heart rate or bradycardia. Now here, go over this beautiful illustration showing you the 4 heart valves. Let's start with my favorite and the favorite of most examiners, the mitral valve. And as you can see, please take note, the mitral valve is the only bicuspid valve. Then we have the tricuspid valve, the aortic valve, then we have the pulmonary valve. Please don't forget mitral valve, tricuspid valve. These are your AV valves, okay, the atrioventricular valves. While the pulmonary and the aortic valves, these are your semilunar valves. So what are the semilunar valves? Bring this with you to the exam. We have the semilunar valves, SAP, aortic and pulmonic valves. Now, what are the AV valves? This is ATM, tricuspid and your mitral valves. Now, tip, the closure of the AV valves, which is the mitral and the tricuspid valves, the closure of the AV valves is responsible for the first heart sound. Now, for those who have a very bad memory, AV valves, letter A, the first letter of the English alphabet, first, that's the first heart sound, letter A. Now, what is responsible for the second heart sound? This is the closure of the semilunar valves, which is pulmonic and aortic. So semilunar, semi, S, second. That's the second heart sound. Now for the conduction system, always remember by heart that the impulse conduction in the heart should start normally from the SA node or the sinoatrial node. This is the pacemaker of the heart. From the SA node, impulses travel down to the atrioventricular node, to the AV bundle, to the bundle branch, which is left and right, until the impulse propagates to the Purkinje fibers. Now here, illustration lifted from your Burnin-Levy. This is your superior vena cava. This is your right atrium. Again, your superior vena cava. This is your right atrium. This is the SA node. Look at the location of the SA node. It lies between the superior vena cava, and it's not shown here, the sulcus terminalis of the right atrium. So the SA node, bring this to the exam, is the pacemaker of the heart, and it initiates the spread of action potentials through the atria. So here's your SA node found in the right atrium. It initiates the spread of action potentials to your atria. And down here, this is your AV node. Memorize the pacemaker of the heart. So where does the SA node lie? It lies in a groove at the junction between the superior vena cava and the right atrium. Now this groove is actually known as the sulcus terminalis. So sulcus terminalis is letter S. Letter S is superior vena cava. Another letter S is the SA node. So what are the three S's? S, A node, S, superior vena cava, S, sulcus terminalis. Now, some terminologies. What is the ability of the heart to initiate its own beat? This is called automaticity. And what is the property of the heart? Okay, the regularity of pacemaking activity. This is called rhythmicity. So automaticity, rhythmicity. Now, what is the property of the heart, or the ability of the heart to initiate an action potential in response to an inward current? This is excitability. Now, memorize this. This is found in your Byrne-Levy textbook of physiology. This should show up in the exams. In the cardiac SA node cells, there is a specific and unique channel known as the IF, or the funny current. Some textbooks call this the funny channels. So again, where do you find the funny current or the funny channels? It's in the cardiac SA node cells. Now these channels are activated by hyperpolarization, and these channels are gated by your cyclic nucleotides. This funny current channel is designated as HCN. This is the channel you see there, HCN. What is the clinical pearl? There is a rate control drug known as ivabradine. Ivabradine blocks the funny current or the funny channel by inhibiting currents and lowering the heart rate by slowing diastolic depolarization. So let's name the drug again. Ivabradine. It blocks the funny channel, inhibiting current and lowering the heart rate by slowing of diastolic depolarization. Now, question. What is the force that stretches the relaxed muscle fibers? The force that stretches the relaxed muscle fibers, thereby increasing their resting length. This is your preload. The force that stretches the relaxed muscle fibers, thereby increasing their resting length. Now, what is the force added to the muscle against which the contracting muscle must act? The force added to the muscle against which the contracting muscle must act. This is your afterload. Do not take the physiology exam without knowing these terminologies. Preload, afterload. Now, what is an increase in contractility? This is what we call positive inotropic effect. So contractility, this is inotropic. So positive inotropic effect, this is an increase in contractility. So your clinical pearl is we have inotropic drugs. Drugs which are used to increase the contractility of the heart. So for example, dopamine, dobutamine. Now, the opposite, a decrease in contractility. This is negative inotropic effect. Reminder, contractility, inotropic. Now, terminologies you must bring to your examination. What is the volume of blood that fills a ventricle during diastole or relaxation. The volume of blood that fills the ventricle during diastole. This is known as your EDV or your end diastolic volume. Memorize the value of approximately 120 ml. Now, what about the volume of blood remaining in the ventricle after systole? The volume of blood remaining in the ventricle after systole is the ESV or the end systolic volume. Memorize the value, approximately 50 ml. Now let's put these two physiologic principles together. The stroke volume, which is the end diastolic volume minus the end systolic volume. Repeat, what is the stroke volume? End diastolic volume minus the end systolic volume. Now let's put in the values. End diastolic volume, roughly 120. End systolic volume, approximately 50. So the stroke volume is about 70 ml. Now, what about the cardiac output? The cardiac output is equal to the heart rate times the stroke volume. The heart rate times the stroke volume. Now, what about the ejection fraction? This is the stroke volume divided by the end diastolic volume. So that would be 70, the stroke volume, end diastolic volume 120. That would give you more or less about 58%. Now, the ratio of the volume of blood, ejected from the left ventricle per beat. The ratio of the volume of blood ejected from the left ventricle per beat. This is your stroke volume. The ratio to the volume of blood in the left ventricle at the end of diastole. This is your end diastolic volume. So the ratio of stroke volume and end diastolic volume. This is your ejection fraction, which is used clinically as an index of contractility. So the most widely used diagnostic tool for the measurement of the ejection fraction would be your 2D echo. Now, some more terminologies. Systolic blood pressure. This is the highest arterial pressure during the cardiac cycle. Systolic pressure occurs when the heart contracts and the blood is ejected into the arterial system. So let's pretend your exam is 5 minutes from now. What should you remember by heart? Systolic pressure is the highest arterial pressure. This is when the heart contracts. Now, what about the diastolic pressure? This is the lowest arterial pressure in the cardiac cycle. The lowest arterial pressure in the cardiac cycle. This occurs when the heart is relaxed and blood is now being returned to the heart via the veins. So again, if your exam is 5 minutes from now, what are the core principles that you should bring with you regarding diastolic pressure? It's the lowest arterial pressure, and this occurs when the heart is relaxed. Now let's put these two principles together. The pulse pressure. This is the difference between the systolic pressure and the diastolic pressure. So if you subtract the systolic blood pressure and the diastolic blood pressure, this would be your pulse pressure. Now memorize this for the exam. What is the most important determinant of stroke volume? It is the pulse pressure. Let me repeat. The most important determinant of stroke volume. The most important determinant of pulse pressure is the stroke volume. Now, the mean arterial pressure. This is the average arterial pressure with respect to time. Now, this is calculated as the diastolic pressure plus 1/3 of the pulse pressure. Now, I personally like this formula which we use in the emergency room and in the wards. 2 times diastolic blood pressure plus systolic blood pressure divided by 3. So that's equivalent to diastolic pressure plus 1/3 of the pulse pressure.